Hello everyone and welcome to our module on valve disease. So in this video we're going to talk about valve disease related to the four different heart valves shown in this picture on the slide here. And there are basically two ways that valves become diseased. The first way is that the valve can develop stenosis. This refers to stiffening and thickening of the valve leaflets. And when that happens, there's an obstruction to forward flow of blood. And we'll talk more later in this video about what that means. The other way a valve can develop problems is with regurgitation. So remember, all four heart valves are supposed to close during parts of the cardiac cycle and not allow blood to flow backwards across them. But if there's malcoaptation of the valve leaflets, meaning that they don't come together normally and seal, then you can get leakage of blood backwards across the valve, and that's regurgitant valve disease. Some valve lesions or valve disorders cause problems in systole and some in diastole. Let's start by talking about valve lesions that are a problem in systole. So these valve lesions create an issue when the left or right ventricles of the heart contract or squeeze. So for example, in aortic stenosis, blood is supposed to leave the left ventricle in systole and go out of the heart and into the aorta. But if the aortic valve is stiff and stenotic, it will obstruct this flow of blood during systole, and that's how aortic stenosis causes problems, which we'll talk about later. In mitral regurgitation, when the left ventricle squeezes, blood is supposed to only go out to the aorta, but it can go backwards into the left atrium because the mitral valve is not sealing, and so that's also a problem in systole. In pulmonic stenosis, there's a problem in systole in that blood can't flow out of the right ventricle into the pulmonary artery. And in tricuspid regurgitation, there's a problem in systole in that when the right ventricle squeezes, blood goes backwards across the tricuspid valve into the right atrium. In contrast, the problems listed on the slide here are an issue in diastole. So these valve disorders cause a problem when the ventricles are trying to relax and fill with blood. So in aortic regurgitation, when the left ventricle is receiving blood from the left atrium in diastole, it also gets blood across the aortic valve going backwards because of aortic regurgitation. In mitral stenosis, during diastole, blood is supposed to flow from the left atrium to the left ventricle across the mitral valve. But in mitral stenosis, there's a problem in diastole because the mitral valve is stiff and thick and it obstructs the flow of blood across the mitral valve into the left ventricle. In pulmonic regurgitation, blood leaks backwards from the pulmonary artery into the right ventricle in diastole. And in tricuspid stenosis, blood can't flow normally from the right atrium to the right ventricle in diastole because the tricuspid valve is stenotic. We won't talk much about treatment of valve disease in this video, but you should be aware that only severe valve lesions are treated. So if someone in your family calls you up and tells you their doctor ordered an echocardiogram and they have mild aortic stenosis or mild regurgitation of the mitral valve, you can let them know that that probably won't require surgery because it's only severe valve lesions that get treated. And most valve disorders are surgical diseases and repaired with heart surgery. Sometimes you can repair valves. Often this is done for patients who have mitral valve prolapse that's leading to mitral regurgitation. Sometimes the surgeon can repair the valve without replacing it. But more often in valve disorders, valves have to be completely replaced with the natural valve taken out and a new valve put in. There are two options for new valves. Patients can receive so-called bioprosthetic valves. These come from pigs or cows. The bad news about these valves is they can break down in 10 or 20 years, but the good news is they don't require anticoagulation. The other option is a mechanical valve, which is metal. The good news is these last forever, but the bad news is the patient has to take lifelong anticoagulation to prevent a blood clot from forming on the mechanical valve. And then finally, in rare specialized cases, you can do valvuloplasty for stenotic lesions. Valvuloplasty refers to breaking up of the stiff, thick parts of the valve so that it opens more easily. And this can be done in a minority of cases of stenotic valve disease. Okay, in just a minute, I'm going to start talking about specific valve conditions. But before I do that, I want to make a couple general points. And the first one has to do with stenotic valve disorders. So like I said earlier, in stenotic valve disorders, the valve becomes stiff and it doesn't open normally. For example, this is a picture of aortic stenosis. These aortic valve leaflets are very thick and they're not going to open normally, and that's going to cause aortic stenosis. Anytime this happens, there will be a gradient across the stenotic valve, and it's very important to understand this concept of hemodynamics. So what's going to happen when there's a stenotic valve disorder is there will be high pressure upstream of the valve and lower pressure downstream, and this will create a pressure change across the valve, and that's called a gradient. So for example, let's imagine we had blood flowing in the left ventricular outflow tract. Remember that when blood goes from the left ventricle into the aorta, it flows out through the left ventricular outflow tract and it has to cross the aortic valve. Now, if this aortic valve is very healthy and opens very easily, then the pressure in the aorta could be something like 80, and the pressure in the left ventricle would just have to be a little bit higher for blood to flow. Let's say it would be 81. And this would make blood flow through the LVOT. And that's because in a healthy aortic valve, there's very little resistance to flow, and it's very easy to get blood to move from the left ventricle to the aorta. But now let's imagine this aortic valve is very, very stiff and stenotic. It's hard to get it to open. Well, now if the pressure in the aorta is 80, what does the pressure have to be in the left ventricle for that valve to open? Well, it can't be 81. That won't do it. It'll have to get much higher, something like 100, or maybe even 120 or 140. And this pressure difference is called a gradient. And so this 20 millimeter gradient that I'm describing here is an example of how you get a pressure difference across stiff stenotic valves. And that's a key thing to understand. We'll come back to that again in this video. But anytime a valve becomes stiff, there's high resistance to flow. That's a key principle here. And that's going to create a pressure drop across the stenotic valve called a pressure gradient. Another topic I want to briefly review before we get into specific valve disorders is acute rheumatic fever. This is a condition that leads to many valve problems later in life. So acute rheumatic fever occurs weeks after someone has strep pharyngitis or strep throat. It's common in children, and it's an example of an autoimmune reaction. It's a type 2 hypersensitivity reaction. What happens in acute rheumatic fever is antibodies develop to bacterial M proteins, proteins found on strep bacteria, and they cross-react with the heart and the joints, and that's what leads to acute rheumatic fever. So like I said, acute rheumatic fever is a condition you want to think of in a child who has strep throat and then a few weeks later develops symptoms like the ones I've shown on this slide. The diagnosis is made by identifying elements of the Jones criteria. And the Jones criteria, each of the letters of the word Jones stands for one of the criteria. So the J is for joints. Children with acute rheumatic fever will develop arthritis of multiple joints, usually greater than 5. The O is for the heart. That's for carditis. So there can be inflammation of the valves. There can be myocarditis or pericarditis. Sometimes this is subclinical, meaning it doesn't cause symptoms. But when echocardiograms are done, they identify inflammation of the valves, for example, or inflammation and a pericardial effusion from pericarditis. The N is for nodules. Children with acute rheumatic fever develop these subcutaneous nodules. They're small bumps under the skin. They're usually non-tender. They form over tendons and bones. The E is for erythema marginatum, which is a rash that usually develops on the trunk. It's not itchy. It's a red rash. And then finally, the S stands for Sydenham chorea, which is a jerking sort of movement disorder. Children with acute rheumatic fever who have this form of chorea have very abnormal movements of their limbs. And the best way to understand this is to go to YouTube. There's lots of videos of children who have this form of chorea. So basically, these are the major Jones criteria here. And when they're present, a diagnosis of acute rheumatic fever is made. But the thing to know about acute rheumatic fever is that's usually not what leads to serious valve problems. It's usually years and years later where heart valves that have been damaged from acute rheumatic fever begin to develop stenosis or regurgitation. And that's called rheumatic heart disease. It's the heart disease that occurs many, many years after acute rheumatic fever. The mitral valve is the most commonly involved valve, so it can develop thickening and stenosis, or it can develop regurgitation because of damage that occurred during an episode of acute rheumatic fever. As I said, this presents years after acute rheumatic fever, and some patients have very mild forms of acute rheumatic fever, so they don't recall having symptoms of acute rheumatic fever, but that doesn't mean they can't have rheumatic heart disease. We still see mitral stenosis and regurgitation in people who clearly must have had acute rheumatic fever years ago, even though they don't remember having that condition. Okay, the last general topic to review before we get into specific valve conditions is carcinoid heart disease. So carcinoid tumors of the intestines, which I talk about in videos in the GI section, secrete serotonin. And for reasons that are poorly understood, this can lead to fibrous deposits on the tricuspid and pulmonic valves. And so patients who have had carcinoid tumors of the intestines can develop stenosis and regurgitation of the right-sided heart valves, meaning the tricuspid or pulmonic valves. Interestingly, these patients almost never get left-sided lesions like aortic valve problems or mitral valve problems, and that's believed to be because the serotonin is inactivated by the lungs, so it flows from the intestines to the right side of the heart, causing problems here, but it's inactivated in the lungs and it doesn't go over to the left side of the heart, and that's why you don't see mitral and aortic valve disease in carcinoid patients. Okay, our first valve condition we'll talk about is aortic stenosis. This is one of the most common valve disorders. You will almost certainly see this in real life on clinical rotations. So it's a problem where the aortic valve becomes stiff. This is a picture of a stenotic aortic valve on the screen here. It's a problem in systole because remember, systole is when blood is supposed to flow from the left ventricle to the aorta, and it has to cross the aortic valve, and that's when you're going to have issues if the aortic valve is stenotic. And then in terms of step one and physiology, it's super high yield to know that when the aortic valve becomes thick and stiff, this increases the afterload on the left ventricle. I talk about afterload in detail in videos on cardiac physiology, but aortic stenosis is definitely a classic condition to cause high afterload. Let's talk about the hemodynamics of aortic stenosis. So I touched on this before, but when the aortic valve has stenosis, the left ventricular pressure in systole will get much higher than the aortic pressure because of the stiff aortic valve. So for example, the systolic pressure in the left ventricle is normally 120, but it could get up as high as 160 in someone who has aortic stenosis. Why is it higher? It has to get higher in order to push open that stiff aortic valve. Then the systolic blood pressure could be normal at 120, but this will create a gradient in systole of 40 millimeters, and that gradient of 40 millimeters is caused by the stiff aortic valve. The stiffer the valve, the higher the gradient. Mild aortic stenosis might have a gradient of 10 millimeters. Severe aortic stenosis could have 40, 50, or 60 millimeters of a gradient. So if we look down at the bottom right side of the screen, this is what the hemodynamic measurements can look like in a patient with aortic stenosis. I've shown you the normal values on the left. On the right are the values from a patient with aortic stenosis. Note that the left ventricular systolic pressure, normally 120, is much higher than normal at 160. Notice also that there's a gradient here of 40 millimeters when normally there is no gradient if the aortic valve is healthy. This is what you see in aortic stenosis. Now, if the aortic stenosis goes untreated, the high afterload will eventually cause the left ventricle to become stiff and thick, and that's basically a form of diastolic heart failure. So in that condition, you can then get high left ventricular end diastolic pressure. This doesn't occur initially in aortic stenosis. Not all patients with aortic stenosis have high LVEDP, but if it's chronic and untreated, then you will eventually start to essentially get heart failure. And this end diastolic pressure here, which I've shown as normal in this table, will start to go up because the ventricle is stiff. It's not filling normally, just like in diastolic heart failure, and so therefore this pressure starts to rise. In the video on heart murmurs, I talk about the murmur of aortic stenosis and I play an example of what it sounds like. But by way of review, aortic stenosis causes a systolic murmur, classically described as crescendo decrescendo. And then you should be aware that syncope is a classic symptom of severe aortic stenosis. And the reason this happens is because the cardiac output can't go up when there's aortic stenosis because of the high afterload. So let me explain what I mean by this. So imagine that we have the left ventricle and then we have a conduit for blood flow. This is the left ventricular outflow tract. Blood is supposed to flow through this outflow tract in systole so that blood can go to the aorta. If a person has aortic stenosis, there's a stiff aortic valve obstructing flow through the left ventricular outflow tract. So it's difficult to get blood out of the left ventricle and into the aorta. This can be okay at rest. Enough blood flow can be passing across the stiff aortic valve to the aorta to meet the demands of the body. But now imagine the person starts exercising and the blood flow to the muscles begins to increase and blood begins to rapidly leave the aorta heading for muscle beds because the person is exercising. Well, the left ventricle will try to increase blood flow to fill the aorta so that the blood pressure doesn't get low, but it can't do that because the aortic valve is blocking the flow. So it's very hard to get high blood flow across this stiff aortic valve. The result is that you don't get enough blood flow into the aorta with exercise. The blood pressure falls and the person has syncope. So that's why syncope is a classic symptom of severe aortic stenosis. You can also develop angina and left heart failure in aortic stenosis, but these are late features that only occur when aortic stenosis has gone untreated for years. Most patients do not have angina and left heart failure when they initially present with aortic stenosis. The reason angina can occur is because after years of aortic stenosis, the left ventricle gets stiff and thick and diastolic heart failure sets in, and this leads to high left ventricular end diastolic pressure. And anytime the left ventricular end diastolic pressure goes up, there's going to be less coronary blood flow. So that's how you can get angina and aortic stenosis. And then whenever the LVEDP goes up, that can raise the pressure in the left atrium, and that can lead to pulmonary edema, and so therefore left heart failure can occur. Why do patients develop aortic stenosis? Well, the most common cause is senile aortic stenosis. This is a condition that occurs in elderly patients. It's basically a wear and tear lesion of the aortic valve. Collagen breaks down, calcium gets deposited, and the aortic valve becomes stiff and thick. And this is why many patients develop aortic stenosis in their 70s, 80s, or 90s. It takes many, many decades for this wear and tear to set in. A reason younger patients sometimes get aortic stenosis is if they have a bicuspid aortic valve, like what's shown on the slide here. Bicuspid aortic valves break down faster than tricuspid normal valves, and so aortic stenosis can set in at an earlier age, like 40 or 50. And then rarely rheumatic heart disease can lead to aortic stenosis, but like I talked about earlier, usually rheumatic heart disease involves the mitral valve. It's very rare, but there is a condition called supravalvular aortic stenosis that can cause the same hemodynamics as aortic stenosis, even though the aortic valve itself is normal. This refers to narrowing of the ascending aorta just above the aortic valve. And it's high yield to know that this is seen in Williams syndrome. Williams syndrome is a genetic deletion syndrome that I talk about in the genetics section. Children born with this condition have abnormal facial features and intellectual disability, and they can have supravalvular aortic stenosis as well. Okay, moving on. Now let's talk about mitral stenosis. So this is a problem where the mitral valve becomes stiff. And this is going to be a problem in diastole, not systole like aortic stenosis. And that's because in diastole, that's when blood flows from the left atrium across the mitral valve into the left ventricle. And if a person has mitral stenosis, that's going to obstruct the blood flow from the left atrium to the left ventricle in diastole. What will happen when the mitral valve becomes stenotic is the left atrial pressure will get much higher than the left ventricular diastolic pressure. We talked about this before, how there's always going to be a pressure gradient across stenotic valves, and that's true in mitral stenosis just like it is in aortic stenosis. So for example, a normal left atrial pressure is about 10. In a person who has mitral stenosis, it could get much higher, as high as 20, let's say. Why does it have to get higher? Because you need a higher pressure to push open those stiff mitral valve leaflets. In addition to the left atrial pressure getting higher, the left ventricular pressure at the end of diastole can get low. Let's say a normal pressure is about 10, it could be low like 5. Why is it low? Because it's hard for blood to flow into the left ventricle in diastole, so the left ventricle underfills. So you get this situation with a high pressure in the left atrium, a slightly lower pressure in the left ventricle at the end of diastole, and a gradient across the stiff mitral valve. And so in this example here, the gradient would be 15. And so I've shown these hemodynamics at the bottom of the screen just to make them clear to you. On the left side are the normal values. On the right is a person with mitral stenosis. And you can see that the systolic pressures are the same in the aorta and the left ventricle, so there's no aortic stenosis here. But we have a gradient between the left atrium and the left ventricle of 15 millimeters. That's not normal. These pressures should be essentially the same, but there's a gradient here, and that tells you that there must be an obstruction to blood flow, and that's what mitral stenosis does. Also, it's high yield to know that when there's severe mitral stenosis, there's going to be decreased preload to the left ventricle. That's because blood can't get across that stiff mitral valve to fill the left ventricle, so you have low preload, and you can see this in patients with very severe forms of mitral stenosis. Mitral stenosis is almost always caused by rheumatic fever. It's very rare for this condition to develop in a person who never had acute rheumatic fever as a child. And the most common symptom is dyspnea, especially dyspnea on exertion. And that's because, like we talked about in the last slide, the LA pressure goes up, and this is going to lead to pulmonary congestion and pulmonary edema. Because remember, the lungs drain into the left atrium. So when the pressure is high in the left atrium, the pressure will get high in the capillaries of the lungs, and this will drive fluid out into the lung tissue. The murmur of mitral stenosis, which I talk about in the video on heart murmurs, is a diastolic murmur. It's described as a rumble with an opening snap caused by the stiff leaflets. And then it's high yield to know for board exams that mitral stenosis can present in pregnancy. So remember, we talked about how there's high left atrial pressure in mitral stenosis. Well, in some women who have mitral stenosis, they'll tolerate this pressure without symptoms until they get pregnant. But during pregnancy, blood volume goes up, so the left atrial pressure gets even higher. And so sometimes the first symptoms occur during pregnancy, and that's when some women are discovered to have mitral stenosis. Tricuspid stenosis is a very rare valve disorder, and I won't spend a lot of time talking about it. It causes a diastolic murmur heard best in the tricuspid listening area, which is the left lower sternal border. It can be caused by rheumatic fever, but if patients get tricuspid stenosis from rheumatic fever, they almost always also have mitral valve disease. And it's more common to develop tricuspid regurgitation from rheumatic heart disease than it is to develop tricuspid stenosis. That's another reason why it's very rare. And then in addition to rheumatic fever, patients who have carcinoid heart disease, as I talked about earlier, can also potentially develop tricuspid stenosis. And then just to round out the stenotic valve lesions, I'll mention pulmonic stenosis, which is also a very, very rare valve disorder. This can occur as a congenital defect in children. Some children are born with fused commissures. The commissures are the spaces between the valve leaflets, but if those are fused, the leaflets can become thickened, and this can lead to congenital pulmonic stenosis. And then pulmonic stenosis can also occur from carcinoid heart disease, but once again, a very, very rare valve condition. Okay, now we're going to switch gears and talk about regurgitant valve lesions. But before I get into specific valve problems, I want to let you know that in regurgitant valve disease, there are acute and chronic forms. The acute forms, which are less common, usually happen from endocarditis. So when bacteria start to grow in heart valves, valves can suddenly develop severe leakage, and this can potentially cause low cardiac output and shock. The sympathetic nervous system can get activated, and there can be increased contractility as the heart tries to work in overdrive to maintain the cardiac output. This is the less common form of regurgitant valve disease. More commonly, what we see is the chronic form. So these patients slowly develop more and more leakage of their valves over time. They won't present in shock. They can develop chronic heart failure if the valve disease isn't diagnosed and treated. And you only see sympathetic activation and tachycardia and all those kind of things if severe heart failure has occurred. Otherwise, these patients can present relatively in a stable state without symptoms of severe heart failure. Okay, let's start by talking about aortic regurgitation. This is a problem where blood leaks across the aortic valve during diastole. So remember, we have the left ventricle and we have the aorta, and blood is supposed to flow out of the left ventricle to the aorta in systole, but then in diastole, the aortic valve is supposed to close so that blood can't go backwards. Well, if there's a problem with the aortic valve and it doesn't close normally, then in diastole, blood can flow backwards across the aortic valve into the left ventricle. What this is going to do is increase the preload. So remember, the left atrium is supposed to be the only chamber that pushes blood into the left ventricle in diastole. But when there's aortic regurgitation, there's a second place for blood to come from. It can flow into the left ventricle from the aorta as well. So you're going to get increased filling of the left ventricle in diastole, and that's going to raise the preload. And anytime the preload goes up, the stroke volume goes up. So that's what you expect in aortic regurgitation. Also, because more blood is flowing into the left ventricle in diastole, it will fill the chamber more and you'll get a higher left ventricular end diastolic pressure. And so if you look at the bottom of the screen, these are the hemodynamics you can see with aortic regurgitation. Notice that the diastolic pressure in the left ventricle, which should be 12, is higher at 15. That's because the ventricle is filling more in diastole with blood from the aorta. And then finally, aortic regurgitation causes a blowing diastolic murmur, and I show some examples of this in the video on heart murmurs. So let's talk about some of the causes of aortic regurgitation. So first of all, if the aortic root is dilated, this can pull the leaflets of the aortic valve apart, and that can lead to regurgitation. So in this image on the slide here, this is a very dilated, enlarged root of the aorta, meaning the portion of the aorta just above the aortic valve, which is about here. When that happens, it can pull the leaflets apart and the valve can start to leak. So many patients with hypertension develop aortic aneurysms, which I talk about in another video, and that can lead to aortic regurgitation. It's also worth knowing for your board exams, even though this is rare in real life, that tertiary syphilis causes aortitis or inflammation of the aorta, and that can lead to an aortic aneurysm and aortic regurgitation. Patients who are born with a bicuspid aortic valve often develop aortic regurgitation. When there are only 2 leaflets instead of 3, the leaflets often don't come together normally, and there's some degree of regurgitation. And bicuspid aortic valves can occur as an isolated congenital defect, but you should be aware that they're common in children born with Turner syndrome, which I talk about in videos in the genetics section. Also, patients who have coarctation of the aorta often have a bicuspid aortic valve. These 2 disorders tend to go together. I mentioned earlier how endocarditis can cause acute aortic regurgitation. And then finally, rheumatic heart disease can cause aortic regurgitation, but this is rare. Like I told you earlier, rheumatic heart disease almost always causes mitral valve problems, But sometimes in addition to mitral valve problems, there's an aortic valve issue as well, like aortic regurgitation. Let's talk about the clinical features of aortic regurgitation. So remember, in this valve disorder, blood leaks backward from the aorta into the left ventricle, and this is going to cause a low diastolic pressure in the patient. This is a classic feature of aortic regurgitation. So to understand this, remember that your blood pressure goes up and down between a high value, which is the systolic pressure, that's about 120 in a normal patient, and a low value, which is about 80 in a normal patient. This low value is the diastolic pressure, the high value is the systolic pressure. Well, the reason the pressure falls is because blood is leaving the aorta and the arterial system of the body and going into tissue beds. It's entering places like the GI tract and the skin and the kidneys, and that's what makes the pressure fall down to the diastolic value of 80. Well, what happens in aortic regurgitation is there's an extra place for blood to leave the aorta and go to. Normally, blood can only go from the aorta out to the tissue beds like the GI tract and the skin and the kidneys. But in aortic regurgitation, it can also leave the aorta and go backwards into the left ventricle. So there's an extra place for blood to go, so more blood leaves the aortic system, and that makes the diastolic pressure get much lower than normal in patients who have aortic regurgitation. So instead of a diastolic pressure of 80, you could get a lower diastolic pressure like 60 or 50 or 40. And this is all caused by blood leaking out of the aorta into the left ventricle, making the pressure fall more down to a lower value in diastole. And so I've summarized these points here. If 120 over 80 is a normal pressure, you could see a pressure of 120 over 40, for example, in someone with aortic regurgitation. This is the low diastolic pressure of this condition. And then because the diastolic pressure gets low, patients with aortic regurgitation have a wide or increased pulse pressure. Pulse pressure is the difference between the systolic and diastolic pressure, so it's normally about 40. But in this example here, it's gotten much higher, as high as 80. And that's because the patient has a low diastolic pressure. It's also because patients with aortic regurgitation have a high cardiac output. Your pulse pressure is a measure of your cardiac output. And in aortic regurgitation, the cardiac output goes up. You have more filling of the left ventricle in diastole. Normally, in diastole, blood can only go into the left ventricle from the left atrium. That's the only way it fills. But in aortic regurgitation, it also fills from blood coming backwards from the aorta. So you get more filling of the left ventricle, that's more preload, and that's going to raise the cardiac output. So that also contributes to the wide or increased pulse pressure. And then finally, it's rare, but historically, before there were treatments for aortic regurgitation, patients would develop a huge list of clinical findings related to the wide pulse pressure. So one of these findings was called water hammer pulses. This basically means bounding pulses on physical exam. You can see this in any patient with a very high cardiac output, but it was classically associated with aortic regurgitation in the old days. In some patients with untreated aortic regurgitation, the diastolic pressure would get so low that they would get dizzy, and so their head would bob every time their cardiac cycle went into diastole. And then there are many, many other clinical findings of chronic severe aortic regurgitation. These are mostly historical. They're pretty low yield for step one, but you can look them up if you wish. Then finally, at the bottom of the slide here, I've shown an example of what the hemodynamics might look like in a patient with aortic regurgitation. So here are the normal values. Here's the patient with aortic regurgitation. Notice the low diastolic pressure and the high pulse pressure. Also notice the increased filling of the left ventricle has raised the diastolic pressure in the left ventricle. Okay, moving on, now let's talk about mitral regurgitation. So in this condition, blood leaks across the mitral valve in systole, and this is going to fill the left atrium with more blood compared to normal. So remember that blood is supposed to go from the left atrium into the left ventricle, and then in systole, when the left ventricle squeezes, blood is only supposed to go in one direction, out of the left ventricle into the aorta. But if there's mitral regurgitation, then in systole, blood also goes backwards into the left atrium. This is going to increase the volume inside the left atrium, and it's going to stretch those myocytes more. And then via the Starling mechanism, they're going to contract more. And so they're going to push more blood than usual back into the left ventricle. And so it's important to understand that in patients with mitral regurgitation, they have increased filling of the left ventricle from the left atrium. And that's a major contributor to the physiology of this disorder. This is going to lead to more preload in the left ventricle. When there's more preload, you're going to stretch the left ventricular myocytes. And by the Starling mechanism, they're going to contract harder, so you're going to get more contractility, and that's going to lead to more stroke volume. So make sure you understand all the reasons why there's high preload, more contractility, and more stroke volume in patients with mitral regurgitation. And then finally, a super confusing but important physiology feature of mitral regurgitation to understand is that the afterload on the left ventricle will be reduced. So to understand this, remember that the left ventricle normally squeezes and pushes blood in systole out into the aorta. And all the forces that resist flow in the aorta generate the afterload. So it takes force to push blood into the arteries coming off the aorta and the arterioles, and that all generates some resistance, and that's the afterload on the left ventricle under normal circumstances. Well, in mitral regurgitation, you basically open a relief valve where blood can go backwards into the left atrium. This makes it easier for the left ventricle to pump blood, actually, because it doesn't have to just resist all these forces. It can let some blood go backwards here and easily get some blood out of the ventricle. So you might have to think about that to wrap your head around that concept. But the bottom line is, when there's a low pressure way for blood to leak backwards into the left atrium in mitral regurgitation, that's going to lead to reduced afterload. And that's a classic physiology feature of mitral regurgitation. Okay, let's talk about the causes of mitral regurgitation. And unfortunately, there are a lot of potential causes of mitral regurgitation, but I'll try to explain to you why they occur so you have an image in your mind that makes it easier to remember all these causes. So the sort of classic cause of mitral regurgitation is mitral valve prolapse. To understand what this condition is, let's look at this cartoon on the slide here. So this image at the top depicts what the mitral valve should normally do when it's healthy and normal. So in systole, when the left ventricle squeezes, the leaflets come together like this, and the chordae tendineae are pulled tight. But the leaflets don't billow or push into the left atrium. They sort of come together at a flat level like this. Mitral valve prolapse looks like what's depicted here. So in mitral valve prolapse, the chordae tendineae becomes stretched, the leaflets billow upwards into the left atrium, and that's why it's called mitral valve prolapse, because the leaflets are prolapsing backwards from the left ventricle into the left atrium. And this commonly leads to mitral regurgitation. When that happens, this form of mitral regurgitation is often called degenerative mitral regurgitation. It's also sometimes called myxomatous, but these all basically mean mitral regurgitation that comes from mitral valve prolapse. And as I said, mitral valve prolapse is billowing of the mitral valve leaflets above the annulus or the ring around the mitral valve. This is a common cause of mitral regurgitation. And in the video on heart sounds, I talk about the heart sounds of mitral valve prolapse, but just by way of review, it causes a systolic click. And don't confuse this with the opening snap of mitral stenosis. That is a diastolic heart sound, the opening snap, whereas the systolic click of mitral valve prolapse is a systolic sound, just like the name implies. Some other causes of mitral regurgitation are shown on this slide. So ischemia and myocardial infarction can damage the papillary muscles, which, as you may remember, attach the ventricle to the chordae tendineae. And so if they become damaged, then they don't function normally, and the valve leaflets don't come together normally, and that leads to regurgitation. You can also get mitral regurgitation anytime the left ventricle becomes dilated. So in patients who have dilated cardiomyopathy, like what's depicted here, and their left ventricle gets huge like this, basically the leaflets get pulled apart, one going in this direction, one going in this direction, and that allows blood to leak backwards. This is sometimes called functional mitral regurgitation because really the mitral valve is healthy. The problem is just the function is abnormal because the left ventricle is so enlarged. And then hypertrophic cardiomyopathy, which I talk about in another video, is also a common condition to lead to mitral regurgitation. Some other causes are listed on this slide. Endocarditis can cause mitral regurgitation, just like it can cause tricuspid regurgitation or aortic regurgitation. This is a picture of a mitral valve here. These are bacteria growing on the valve leaflets. And so when that happens to a patient, the leaflets aren't going to come together normally and blood is going to leak backwards into the left atrium. As I told you earlier, rheumatic heart disease most commonly affects the mitral valve, and it can lead to either mitral stenosis or regurgitation. And then there are some congenital heart conditions that are associated with mitral regurgitation. One of them is called a cleft mitral valve. This is an example of an endocardial cushion defect. It's common in Down syndrome, and I talk about Down syndrome and all the associated congenital problems with that condition in videos in the genetics section. In the video on heart murmurs, I play an example of the murmur of mitral regurgitation, but just by way of review, it causes a holosystolic murmur best heard at the apex. There are basically three causes of a holosystolic murmur you should know. One is mitral regurgitation, which we're talking about now. The other is a ventricular septal defect. And the final one is tricuspid regurgitation. So anytime you see a board question describing a holosystolic murmur, think of these three conditions and then try to find other clues to figure out which heart condition they're describing. All right, moving on, let's talk about tricuspid regurgitation. So first of all, you should know that almost all of us have a very small amount of tricuspid regurgitation. This is called physiologic tricuspid regurgitation. So once again, when your family member gets an echocardiogram and they call you and say, I have mild tricuspid regurgitation, should I be worried? You can tell them that most likely they're going to be fine. This causes a holostolic murmur, as I just mentioned on the last slide, but it's heard best at a different location for mitral regurgitation. It's usually heard best at the left sternal border, not the apex. And there are a number of pathologic causes of tricuspid regurgitation. Most of them are fairly obvious if you think about it. So you can get functional tricuspid regurgitation if the right ventricle is dilated. So for example, a patient with pulmonary hypertension who has an enlarged right ventricle is going to have a substantial amount of tricuspid regurgitation because the ventricular enlargement is pulling the leaflets apart. Endocarditis, especially associated with IV substance use, classically leads to tricuspid regurgitation. So remember, patients with substance use disorders can inject bacteria into their veins when they're trying to inject drugs. And from the veins, those bacteria will go directly to the tricuspid valve, and that's where the endocarditis will develop, and that often leads to tricuspid regurgitation. Carcinoid heart disease, which I mentioned earlier, can affect the tricuspid valve, leading to regurgitation. And then finally, in the videos on congenital heart disease, I talk about Ebstein's anomaly, which is a congenital heart condition where the tricuspid valve is displaced and not in its normal location, and patients with that condition commonly have tricuspid regurgitation. And then I'll finish by talking about pulmonic regurgitation, which is a very rare valve disorder. The thing you want to remember about this valve disorder for your board exams is that the most common cause is repaired tetralogy of Fallot. So in the videos on congenital heart disease, I talk about tetralogy of Fallot. And when patients are born with this condition, they have surgery to relieve the right ventricular outflow tract obstruction that they're born with. This surgery almost always leaves behind a damaged pulmonic valve. And so these patients commonly have significant pulmonic regurgitation. Super high yield to know this for your boards. This is where pulmonic regurgitation is most likely to come up. You also can get pulmonic regurgitation from endocarditis, but that's rare. And you can get it from rheumatic heart disease, but that is also rare. And that concludes our module on valvular heart disease.